morning. My name is Guy Ringler, and I'm a reproductive endocrinologist with California Fertility Partners in Los Angeles, where I've been practicing reproductive medicine for the past 24 years. I've dedicated my career to helping all individuals with obstacles to getting pregnant to have children of their own, including patients affected by HIV. I'm very happy to be here today with my distinguished colleagues to present this educational project of the American Fertility Association and the Elton John's AIDS Foundation on HIV and fertility. The two main goals of this webinar are to discuss the impact of HIV on male and female fertility and to review the treatment protocols and assisted reproductive procedures that have been used both to minimize the risk of viral transmission from HIV-positive men to their reproductive partners and to improve their chance for pregnancy. First, I'd like to thank some of the sponsors for this webinar, especially the Elton John's AIDS Foundation for their generous support, and the board and staff of the American Fertility Association for addressing the needs of our patients with HIV, and the Growing Generation Surrogacy Agency for their testing program and support of this program. I'd like to introduce my panelists for today's webinar. Dr. David Hardy, Clinical Professor of Medicine at the David Geffen UCLA School of Medicine, and Dr. Ann Kiessling, the Scientific Director of the Bedford Stem Cell Research Foundation here in Boston. In the 1980s, when HIV/AIDS was initially discovered and cases were diagnosed, the life expectancy of an infected individual was approximately 10 months. In 1990, the first antiviral medication, AZT, was introduced, and the life expectancy increased to approximately 20 months. During this time period, patients were advised not to get pregnant due to both the short life expectancy of individuals with HIV and the high risk of vertical transmission from mother to baby, up to 35% in pregnant women. The introduction of highly active antiretroviral therapy, or HAART, in 1996 led to a dramatic increase in life expectancy and quality of life for men and women with HIV. For patients in areas where HAART is readily available, HIV is now considered a manageable chronic disease. Since new infections are most prevalent in men and women of reproductive age, this improved quality of life often includes the desire to have children of their own. Assisted reproductive technologies, or ART, are procedures used to assist chances for pregnancy in each cycle. These procedures include intrauterine inseminations, or IUI, and IVF, in vitro fertilization, oftentimes with ICSI, to assist fertilization. These ART procedures, in combination with specialized sperm washing protocols, have been used to decrease the risk of HIV transmission from HIV-positive men to their negative reproductive partners. HIV is a retrovirus that affects T lymphocytes and can lead to the development of AIDS. The virus is found in blood, semen, vaginal secretions, and breast milk. The predominant method of transmission is through heterosexual intercourse. The risk of transmission from mother to baby can be up to 35% in women not on antiviral medication. And the serum viral load is one of the chief predictors of the risk of transmission of this virus. And there's some correlation between viral loads and serum and viral loads in semen. In general, with increasing viral loads in the serum, there's detectable viral loads in the semen, but it's not a direct one-to-one correlation. One of the attempts to lower the risk of transmission is to decrease the viral loads in the serum through antiretroviral therapy, which will, over time, lead to a decrease in the presence of the virus in the semen, which Dr. Kiessling is going to talk to us about a little bit later this morning. I'd now like to introduce Dr. David Hardy, who's going to talk to us about the impact of antiretroviral therapy on patients with HIV.
Thanks, Dr. Ringler. Similar to Dr. Ringler, to Guy, I've been working in this field of HIV care for about 32 years, since 1982, when I first saw my first patient with HIV. And over that time, have witnessed dramatic changes in what we can offer to persons with HIV infection. I'm going to highlight some of the strides we have made in terms of being able to have individuals with HIV live longer and enjoy parts of their lives that they may had never thought they could enjoy, such as parenthood, and really show how this disease has been changed dramatically in terms of its management and also expectations for those who are living with it today. This was our first indication that our antiretroviral medications were working. Now on this slide, the acronym ART does not stand for Assisted Reproductive Technologies. It stands for Antiretroviral Therapy. And the thing that really makes it special and makes it work is that it's been used in combination. A HART regimen, as you heard Dr. Ringler say previously, or a CART regimen, a combination antiretroviral therapy regimen, are really the same thing. They're just simply putting medications together with a minimum of 3 medications used together, which is why the medications work. They successfully and durably suppress the virus. And from this slide that was taken from 1995 through 2001, we saw a dramatic uptake of HART regimens, or CART regimens, here just called ART, and a dramatic fall in deaths. Up to that time, HIV was pretty much a death sentence for most patients who were diagnosed with it. And with this effective therapy, things changed dramatically, almost overnight, in terms of being able to offer patients something that would change their lifespan, their lifestyle, and their quality of life as well. Probably, and most relevant to this area that we're talking about today, has been the use of antiretroviral therapy in pregnant women in order to be able to stop transmission of the virus from mother to child. As Dr. Ringler just mentioned, transmission from mother to child before ART or HART was used was somewhere as high as 35%. And this was something that, of course, was only feeding the epidemic longer, having babies being born with HIV. HART really changed this, and giving HART to the mother has almost dropped to 0 the number of cases in the United States. There's still somewhere around 200 per year. It's estimated by the CDC. But we've seen a dramatic drop, as this slide shows, in how often HIV is transmitted to a baby by the mom with the use of antiretroviral therapy on board from the earliest stage of pregnancy. HART's also gotten much, much better. When we first started using HART back in the 1990s, our success rate was hampered by the fact that medications were hard to take. There were too many pills to be taken, as many as 20 to 30 per day. The side effects oftentimes were very limiting. So HART was a good thing, but it was oftentimes unachievable in terms of being able to have patients take it on a well stick-to basis. Over the past 20 years, we've noticed that there's been a dramatic increase in the efficacy of HART, and as this large meta-analysis shows, the efficacy of HART has increased from about 43% back in 1995 up to almost 80% by 2010, indicating that our ability to suppress the virus in individuals who are HIV positive has gotten to be very, very good. And our latest studies are showing that we're actually reaching towards about 90% of individuals who can take HART can actually have well-suppressed virus below the limit of detection of our blood measuring tests. The other thing I want to also point out was another aspect of what HART has been able to do. Not only does it protect the individual from HIV's ravages of clinical disease progression, but it also protects others who may interact with the individual, particularly in a sexual sense. This study, called HPTN-052, or the HIV Prevention Trials Network Study number 052, demonstrated that in almost a little over 1,700 serodiscordant couples, defined as one of the persons in the couple is positive, one of the couple members is negative, was actually looking at the introduction of HART at an early point versus a late point to see what effect this had primarily on the transmission of virus from the positive member of the couple to the negative member of the couple. This study was done primarily in Africa, Asia, and some sites in Southeast Asia, and a few in the United States as well. Basically, what this study did was that it randomized individuals to begin HAART, the HIV positive member of the couple to begin HAART immediately, irregardless of their CD4 cell count after entering into the study, or wait until their CD4 cell count fell below the number of 350, which at that time was the World Health Organization cutoff point or threshold for starting HAART. What the results of the study show was really dramatic, and this was in fact in 2011 the Science magazine breakthrough of the year. It demonstrated that there was a 96% relative risk reduction in the transmission of HIV if the HIV positive partner was on HAART, indicating that there was ability to really stop transmission of this disease from a positive person to a negative person by the use of this medication. So not only was this an important effect in terms of protecting the individual from the ravages of HIV disease, but also protecting the public on a one-on-one basis from individuals who may interact with that person on a sexual encounter. The last thing I'll mention here is something that's kind of new and different, but it will have some interplay in terms of what we're talking about today, and that's what's called PrEP, or pre-exposure prophylaxis. PrEP is an all new and different way that we're using antiretroviral medications, not as highly active antiretroviral therapy regimens, but simply as two medications being given to an HIV negative individual to protect them from HIV infection. In 2012, the US FDA recommended one medication, one medication called Truvada, which is two medications in one pill, to be given to HIV negative individuals who are at high risk of HIV infection. We'll talk more about this concept in the future of this webinar, but actually this is a way that we can actually use antiretroviral medications in a new and different way to protect those who are negative from becoming infected. Pass it now over to Dr. Kiessling.
The assisted reproductive procedures of IUI and IVF are used to help minimize the risk of viral transmission for men with HIV. A basic component of assisted reproductive procedures involves doing a sperm wash. So a sperm wash literally separates the sperm from the seminal fluid and non-spermatozoal cell components in semen. And we know that HIV does not exist inside the sperm, but it exists in the semen as a cell-free particle or infected white blood cells. So if we can literally wash away the semen and the non-spermatal cells from the sperm, we should be able to minimize the chance of virus being present in that specimen. In this study from Human Reproduction last year by Savasi, he reviewed the world's literature on the application of assisted reproductive procedures in men who are HIV positive. He reported on 3,200 cycles. Over 6,200 couples underwent intrauterine insemination. Over 1,600 couples did IVF with ICSI. There were 320 children born, and there were no seroconversions reported in either the women or the children. A more recent study published earlier this year was a meta-analysis looking at the efficacy and safety of IUI and IVF in patient populations serodiscordant for HIV. They reviewed the world's literature. Over 200 studies were reviewed. 24 clinical studies were included in the meta-analysis, and this patient populations involved seropositive men and there's seronegative females. 8,200 IUI cycles were reported, and 1,250 IVF cycles, and no transmission of HIV to mother or baby were reported in this study. What are the impacts of HIV on semen parameters in men with HIV is we oftentimes will see a decrease in volume, concentration, motility of the sperm, so a decrease in the sperm quality and quantity. And there have been reports that HAART, highly active antiretroviral therapy, can negatively impact the sperm parameters. So when we see men with HIV, their sperm numbers are low. It's important after the sperm wash to quantitate the amount of sperm present, and it helps our decision making as to whether or not they're a candidate for an IUI or an IVF ICSI cycle. Ideally, for patients considering intrauterine insemination or IUI, we'd like to have 2 to 4 million motile sperm after the wash. If we have less than 2 million motile sperm, the pregnancy rates are significantly lower with an IUI, and we will recommend IVF with ICSI, where we can help the sperm function. We can assist the sperm in fertilizing the egg. In the ICSI procedure, we take the washed semen sample, isolate one normal moving sperm, and inject it into each egg. And this will provide a near normal to normal fertilization rate of approximately 75%. Another potential benefit is rather than exposing the egg to thousands, hundreds of thousands of sperm, with the possibility of some virus being present around the sperm, we only expose one egg to one sperm through the procedure. For individuals with HIV undergoing assisted reproduction procedures, it's helpful to test the semen for the presence of virus, and we've been working for the last 5 to 8 years with the Bedford Foundation in their SPAR program, Special Program of Assisted Reproduction, that Dr. Kiessling is going to tell us a little bit more about shortly. And they combine PCR testing of semen samples for the wash for the presence of HIV, and wash the sperm and freeze it. So when we begin the assisted reproductive procedures, we know we have a specimen that's tested and found to be free of virus. Dr. Kiessling.
Thank you, Guy. Like Dr. Hardy, we've been studying HIV since the very beginning of the pandemic. This is an old electron micrograph that was taken in 1983 and demonstrates an HIV particle very close to the mid-piece of a sperm. So we know that we've known the virus was in semen for a long time. Some facts that are of interest to people considering going through assisted reproduction is that HIV infection at fertilization, if the egg were actually infected with HIV, there's a lot of evidence that indicates there wouldn't be a pregnancy. So there is very little concern about having a baby that's HIV infected. And there have never been any reports of an HIV infected baby from an uninfected mother. The risk of transmission, as we mentioned earlier, the risk of transmission to fetus is greatest during delivery, and infecting approximately at least 20% of newborns if the HIV-infected mother is not on antiviral therapy, and if she is on antiviral therapy, that number goes to almost zero. So the risk of transmission to the baby approaches zero. Now, one interesting Supreme Court ruling that I think is not very commonly understood is in 1998, a case came to the Supreme Court by a woman who was HIV infected. And the Supreme Court looked at her case and came out with a ruling that had 3 basic points. And the first point was that the Supreme Court decided that healthcare professionals, in this case it was a dentist, do not have a special standard to determine risk. They cannot rely on their own individual judgment. Objective medical evidence must be used. Secondly, asymptomatic HIV disease constitutes a physical impairment, and this physical impairment in this case, in the judge's view, was that reproduction is considered a major life activity. So this ruling places people with HIV disease under the American Disabilities Act, and they should be entitled to the same standard of care that the ADA affords everyone, and it's because their reproduction, which is a major life activity, is impaired. Now, as Dr. Ringler mentioned, the recent meta-analysis of reports since 1998 revealed no reported case of HIV transmission. Even in the face of this report, however, I think it's important to notice that the Centers for Disease Control has not reversed its recommendation against insemination with sperm from an HIV-infected man. So there's now some difference between one of our main government agencies and the data that we have at hand. Consequently, there are still two approaches to providing safety to HIV-negative female partners undergoing either intrauterine insemination or in vitro fertilization, as Dr. Ringler mentioned. There's something called sperm washing, which is a term that was invented many years ago. Or what the Bedford lab does is we actually screen specimens prior to the washing procedure. Sperm washing is reported, no method of sperm washing is reported to eliminate HIV from 100% of specimens. The density gradient plus swim up is the most effective, but the published data indicates that it eliminates 92% of it, and approximately 8% of sperm processed in that way are still positive for HIV. In the Bedford lab, year after year, we see approximately 15% of semen specimens from men on antiretroviral therapy continue to test PCR positive for HIV. This is probably a combination of free virus particles, HIV RNA, and virus-infected cells, which appear in the semen on a sporadic basis. HIV in semen is very random from specimen to specimen if the man is on antiretroviral therapy. If he is not on antiretroviral therapy, HIV in semen is more consistent. And it seems to be very discordant with the burden of virus in his blood. So the Bedford program, the special program of assisted reproduction, takes advantage of the fact that 85% of semen specimens test undetectable for HIV by PCR. So 85% of the specimens are the ones that are used for the sperm washing. If we test washed sperm from that 85% of specimens, none of those washed sperm samples have HIV in them. Half of the specimen is used for the initial screen. So the program recommends that 2 specimens be tested so that there's an equivalent of 1 semen specimen for the IVF or the IUI procedure. Now, surrogacy cases for HIV gay couples pose another level of federal oversight. And surrogacy cases are considered like any kind of tissue donation. The intended parents, whether they are HIV infected or not HIV infected, need to go through a panel of infectious disease testing just as if they were donating a kidney to the surrogate. And that FDA disease panel has to be conducted and paired to their semen specimens within 7 days, just as if they were donating kidneys, or liver, or eyes. Their testing requirements are quite specific. They have specific methods that they want used for the infectious disease testing. Gay couples can come to Boston to do all of that, or they can also go to Dr. Ringler's laboratory in LA. We need an interview with these couples so that we can establish what their history is and their current compliance, because if their specimens test positive for virus, we need to figure out what they need to do to be able to produce specimens that they can use for their assisted reproduction. And it's not common that all the specimens from an individual test positive for virus, but it happens occasionally. Then we have to figure out, does this individual need to go visit a urologist because there is an infection in one of the semen-producing organs, which is leading to an increase in HIV-infected leukocytes in his specimen? Or does he need to change to a new antiviral medication which has better penetration into the semen compartment? In that case, all of the testing needs to be repeated for this individual. Now, for the benefit of the surrogate, the specimens that test negative for HIV are further tested by PCR for other pathogens that might show up on the infectious disease screening panel, such as CMV, syphilis, hepatitis C. The program also we do a phone interview with the surrogate, mostly to answer her questions, to talk to her about confidentiality issues, and to make sure that she understands that we cannot guarantee that there is no risk for HIV. We think we have eliminated the risk, but statistically, there aren't enough babies from this program. We need about 400. It's important to everyone that the surrogate needs to be HIV antibody tested at 3 weeks, 3 months, and 6 months after the embryo transfer, whether or not she is pregnant. These are exactly the same standards that are used for wives, for serodiscordant couples, for wives of men with HIV disease. They need to be tested 3 times after the embryo transfer. The current baby count for the SPAR program is it's at least 223 babies. There are about 72 collaborating clinics in the US and Canada. For heterosexual couples, about 15 collaborating clinics for gay couples using surrogacy. And we would very much like to streamline this assay.
Fertility options for gay men with HIV include donor egg and surrogacy and specialized testing of the semen samples to be used in those IVF cycles with the donor eggs. So we can do testing on the semen through the Bedford Foundation, or there's another program in Los Angeles called the HEART program, where they wash the sperm and test the washed semen sample for the presence of HIV. These prepared samples can be used in an IVF cycle using donor eggs to create embryos, and the embryos are then transferred into the gestational carrier. In our program over the last several years, we've carried out 56 treatment cycles. These are HIV-positive gay men with egg donation and surrogacy. We've had 44 pregnancies, either ongoing or delivered, providing a pregnancy rate of 79% for transfer. And all of the surrogate mothers and all the babies born have been HIV negative. We have 100% very happy, very appreciative dads for the women, surrogate mothers and egg donors who assist them in helping to build their families. Patients often ask, will it be difficult to find a surrogate who's willing to work with me if I'm HIV positive? And in general, it may take a little additional time, an additional several months to find the perfect match. But we haven't found difficulty, and we've worked with the following surrogacy programs to provide surrogate mothers. Not all surrogacy agencies are willing to help patients with HIV. We work with the Center for Surrogate Parenting in Los Angeles, Circle Surrogacy here in Boston, Growing Generations in Los Angeles, West Coast Surrogacy in Southern California, Surrogate Alternatives in San Diego, and the British Surrogacy Center of America. All these agencies have helped me help men with HIV to have children. And this is a case that I'm going to let David present. These are patients that we worked on together, a gay couple with HIV who now have twins.
Thanks, Guy. I specifically chose this case because all 3 of us on this panel were involved in this successful production of two baby girls for these 2 men. And in this case, it was a bit of a challenge because both men are HIV positive in this couple, and both men wanted to become fathers. So these are 2 individuals who moved to Los Angeles for part of their work. They're 2 highly successful men in the entertainment industry. Their antiretroviral histories, which is what I've concentrated on primarily in my part of this case, were the same. Interestingly, they were both infected by the same individual, had the same virus as best we could tell. And initially, we started on the triple combination medication of efavirenz, tenofovir, and FTC, a drug commonly called a triplo. On this medication, one of the members of the couple, John, had a well-suppressed viral load. Every time we checked it over several months, I was following him, and had a well-reconstituted CD4 cell count of over 650. Jim, however, had a viral load that sometimes was undetectable, less than 50 copies, but sometimes was detectable at low levels, and was concerning because of the fact we could not get a consistent undetectable virus from his plasma RNA assay. His CD4 cell count was also very good, over 700 cells. In terms of trying to make sure that both men had undetectable virus in their plasma prior to sending them for semen sample collection, we maintained John on his medication regimen of efavirenz, tenofovir, and FTC, but with Jim we had to change him to a different kind of regimen, a different kind of approved regimen by our Department of Health and Human Services. We changed him to a combination of darunavir boosted with ritonavir and tenofovir FTC. And on this regimen, his viral load now became in the plasma consistently undetectable, less than 50 copies. We referred him, first of all, to the fertility specialist, Dr. Ringler, who then was able to act as the conduit for sending semen specimens on both these men for testing to Dr. Kiessling's laboratory. In vitro fertilization of the purchased eggs and the implantation in a paid surrogate mother was conducted. Of note, this occurred after an important law change in California after 2008, when it became legal for a fertility specialist such as Dr. Ringler to be able to use semen from HIV positive men to do in vitro fertilization. Following persistent plasma suppression, the Bedford lab accepts and certifies the semen from both men being HIV negative, or undetectable, and as well as other infectious agents. Unfortunately, the first attempt at pregnancy was failed. The second attempt was successful, and the event, after an uneventful pregnancy and normal vaginal delivery, were 2 healthy daughters with weights of 6 pounds 7 ounces and 7 pounds 2 ounces. The girls are now 4.5 years old and doing very, very well. One looks exactly like one of the fathers, one looks exactly like the other fathers. A father as planned, and the total cost was around $200,000 for both of these attempts of safe pregnancy.
I'd like to talk a little bit about the impact of HIV on fertility in women. Women with HIV have some special considerations, special problems have been found. For one, we see an increased incidence of anovulation and even amenorrhea, absence of menstrual cycles, despite normal FSH levels, meaning they're not showing signs of ovarian failure, but long periods of amenorrhea. In general, women with HIV have a higher incidence of tubal occlusion than the general non-HIV infected infertility population. And in general, the pregnancy rates are a little bit lower. They're less likely to conceive than uninfected women. And there is some correlation between advanced disease, low CD4 counts, and lower pregnancy rates per cycle. And there have been reports, especially earlier in the history of HIV, with increased incidence of pregnancy termination. Women were found to be pregnant, and they were nervous about the impact of the HIV on the pregnancy, and they did not want to risk infection to the child. There are several studies looking at IVF pregnancy rates, some studies showing lower pregnancy rates for IVF cycles, others showing comparable results. We know that highly active antiretroviral agents are mitochondrial toxins, which could have a negative impact on the eggs and the embryos, making them less viable, less likely to implant to initiate a pregnancy. However, they're necessary. They reduce viral load to undetectable levels, which is extremely important in pregnancy to minimize the risk of vertical viral transmission to the baby. And as David is going to talk about a little bit later, there's been no significant increase in birth defects found to the offspring in women taking antiretrovirals during their pregnancy. For women with HIV who come in for fertility evaluation, it's due to the impact on ovarian function. It's very important to test their ovarian reserve. We can do this with a blood test for AMH, which stands for anti-Mullerian hormone, or cycle day 3 FSH and estradiol levels. AMH levels decrease with ovarian aging, and FSH levels increase with ovarian aging. It's important to confirm ovulation and do a pelvic ultrasound both to assess the activity in the ovaries and to look for the presence of hydrosalpinges, which are blocked fallopian tubes filled with fluid. Hysterosalpingogram as well, basic infertility test to test for the patency of the fallopian tubes. Infectious disease screens and a semen analysis on their unaffected male partner is an important part of the basic infertility evaluation. David?
As I launch into this part of the webinar, I also want to acknowledge the input and advice I received from a colleague of mine by the name of Dr. Kathleen Squires, the chief of the Infectious Disease Division at Thomas Jefferson Medical School in Philadelphia. Kathleen couldn't be with us today, but I wanted to make sure that she was acknowledged in terms of helping me deliver this part of the webinar. Because the overlap or the interface between pregnancy and antiretroviral medication has been one that has been very commonly used in this area. There have been, of course, a lot of evidence-based results, evidence-based studies that have been done in order to try to make this as rational as possible. Recently, the Department of Health and Human Services panel on this particular area of treatment of HIV-infected pregnant women and prevention of perinatal transmission put out a new set of guidelines as of March 28, 2014, which I'll review in some moderate detail now. Basically, what the principles about using antiretrovirals in pregnancy is that all women who are wanting to get pregnant or who are pregnant or who are about to deliver should be treated with antiretroviral medications regardless of any of their HIV-specific parameters, meaning their HIV RNA, their viral load, or their CD4 cell count. The other thing is that when a woman is first known to be pregnant, that she should definitely be started on medication or have it modified to make sure that those antiretroviral medications she's on are as pregnancy-friendly as possible. These guidelines really make point of the fact that combined antepartum, intrapartum, and infant antiretroviral prophylaxis is very important in stopping the transmission of virus from mother to child. When selecting these medications that we use in pregnancy, it's really pretty much what we do for everyone in terms of looking at a regimen's effectiveness overall, looking at whether or not there's co-infections with viruses, particularly hepatitis B, which we have to also look at in terms of suppression with our antiretrovirals. Particularly in this case, of course, the teratogenetic potential of the medications used in the combination antiretroviral regimen, and of course, any potential negative outcomes for either mom or fetus. The other thing we want to make sure of, just like we do with any person starting antiretrovirals, is to know as much about the patient's virus as possible by doing resistance testing to look to see whether or not the virus has any genetic resistance, which may not allow the chosen medications to work well. The bottom point with the guidelines is basically that we use medications in pregnancy. It's pretty much the same as we do for any woman who is not pregnant. So what we really learned is that pregnancy does not change our selection of antiretroviral medications for a regimen that much at all, and I'll show you where that's different. It is important, however, to make sure that there's at least one medications from the class of antiretrovirals called nucleoside reverse transcriptase inhibitors. It is because this class of medications has been repeatedly shown to have high placental transfer in order to be able to protect the infant from potential HIV infection. And probably the most important thing I've learned about this, of course, is very close coordination between the HIV specialist, the infectious disease doctor usually, and the obstetrician, oftentimes a high-risk obstetrician or a specialist in terms of dealing with women who are HIV positive and pregnant. The antiretroviral combination regimens are shown here. Basically, we use the same kind of formula that we use for any antiretroviral medication, meaning two nucleoside reverse transcriptase inhibitors plus either a ritonavir boosted protease inhibitor or a non-nucleoside reverse transcriptase inhibitor as well. We try to individualize these as much as possible, looking at things such as comorbidities, possible resistance, any PK changes, pharmacokinetic changes that can occur with the volume increase in the third trimester of pregnancy, try to maximize placental transfer, and also just kind of work as best we can in terms of the woman's own personal experience with medications in her life before pregnancy. This table really, I think, summarizes what the current recommendations for the use of antiretrovirals in a woman who wants to get pregnant or who is pregnant is really all about. They have been broken down into agents in the different classes of medications from the 5 different classes of HIV medications we currently deal with now, and puts them into what's called recommended, alternative, insufficient data, or not recommended categories. As you see across the top there, and I'll just really focus on the recommended agents, there are 2 boosted protease inhibitor regimens, boosted protease inhibitor agents, boosted atazanavir and boosted lopinavir, which are recommended in pregnancy. Of note, in the non-nucleoside RT inhibitor category, there is one, efavirenz, which of course has an asterisk. And I'll go about that in just a minute, because as many of you probably have already known, efavirenz has the unique categorization as a category D medication in terms of causing birth defects. In terms of nucleoside RT inhibitors, we have abacavir and 3-TC, tenofovir and FTC, each of which are co-formulated in 2 medications in 1 pill, or our oldest drug in the use of HIV pregnancy, zidovudine or AZT with 3-TC. The alternative agents actually include other medications such as other boosted protease inhibitors, darunavir or sequinavir, nevirapine for women who have CD4 cell counts less than 250, and finally one of our newest medications called raltegravir. Pretty much everything else on this slide is considered to be not enough information to be used, or some not recommended whatsoever. Now in the case of efavirenz, this is a medication which has the unique distinction of being a category D medication, meaning that it definitely does cause birth defects in women and babies of women who are on it. But as the panel has now decided, because the risk of neural tube defect is restricted to the first 5 to 6 weeks of pregnancy, and pregnancy is rarely recognized before 4 to 6 weeks, and unnecessary changes in antiretroviral therapy regimens may lead to the loss of viral control, which is considered to be even more risky than potentially exposing a child to these medications. They are now saying that efavirenz can be continued in a pregnant woman if she's tolerating it well and if it's working well, producing virologic suppression. This is one of the biggest changes to the guidelines that happened this year. And it really comes from this information. Unfortunately, some of our best evidence is really not great evidence in terms of looking at antiretrovirals in pregnancy, because women oftentimes are excluded from, pregnant women are excluded from almost every antiretroviral trial, and therefore we are really left with looking at clinical experience of passive reporting of antiretroviral outcomes of women who are on antiretrovirals and who are pregnant. This is the results of that registry. It's an international registry which enrolls about 1,300 women each year. 80% are in the United States. This covers approximately 18,488 live births through July of 2013, when this was actually examined. And basically what they found, and as Dr. Ringler mentioned earlier, the overall birth defect prevalence compared to CDC population-based survey data was basically very much the same, 2.9 versus 2.7 per 100 live births. Really no difference there whatsoever. And as I've underlined here at the bottom of that table, what we can see is that efavirenz, the category D drug, actually has no higher incidence of birth defects than any other medication on the list there. So that's why efavirenz has now been added as part of being an okay drug after the first 5 to 6 weeks of pregnancy. Slide. The pregnancy registry is something that is very important for anyone who knows of or is taking care of a pregnant woman on an HIV positive woman on antiretroviral medications to really report what came out of that pregnancy. Here's the information about that on the website, which is basically very easy to look at, the APR pregnancy, aprregistry.com. For those of you who may have concerns or problems or need consultation about perinatal HIV, there's a hotline here with that number shown there. So we'll go for just a second for you to copy down. But this is a almost 24-hour available hotline that can give you information about how to handle women who are HIV positive or who were discovered to be HIV positive during pregnancy. Hand it back over to Dr. Ringler.
Before we open the webinar up for open to questions, I just want to briefly introduce the concept of PrEP for safer conception. PrEP, namely Truvada, and that this is a very small series of patients published in 2005, reporting 37 serodiscordant couples, HIV positive men, with their HIV negative sexual partners. And the men were on antivirals for at least 6 months, and they reported on 170 intercourse cycles timed with an ovulation kit. And the uninfected female partner took tenofovir or Truvada to prevent exposure to virus and to minimize the risk of infection. She took 1 tablet in the morning of the ovulation kit change and 1 tablet 24 hours later with timed intercourse. And over the series of cycles, there was a cumulative pregnancy rate of 75%, and he reported no seroconversions in the mothers or babies from this small series of patients. And in our discussion today, we're going to talk about this concept of another method to minimize risk of exposure to for serodiscordant couples who are interested in having children. So that concludes the formal part of the seminar. I'd like to open it up to the panel up to questions. And I'd like to start with a very general question for Dr. Kiessling and Dr. Hardy. I talked with couples today who would like to get pregnant. The man is HIV positive. Their primary concerns are safety, access to treatment, and cost. Dr. Kiessling, Dr. Hardy, how would you address those concerns for patients?
I should start. The considerations for an HIV-infected father planning to have children is his health. He needs to be in good compliance. He needs to be in the care of a knowledgeable HIV specialist because overall his health is important. And then we recommend that they use sperm from specimens that have been screened and found to be relatively or as free of HIV as we can assure for their attempt. Now, we have for many years hoped that most fertility programs would offer insemination rather than having IVF with ICSI be the first form of treatment for these couples. We think these couples should be treated like any other couple presenting for a fertility issue. Most fertility clinics start out with a less complicated approach to getting pregnant, such as a vaginal insemination or an intrauterine insemination. That becomes entirely dependent upon the sperm count, but very few clinics have actually opted to go that route because of the Centers for Disease Control's position on this. But a few centers have, and there's an increasing number of programs in the states that are actually willing to put in place intrauterine insemination as a clinical trial. There's one at Johns Hopkins and there's one at the Mass General Hospital in Boston.
You know, I think this is a very, very relevant question, Guy. I'm glad you brought it up because in the patients that I follow, increasingly both heterosexual couples who are serodiscordant, positive man, negative woman, and even more so now, positive men, which are positive, want to have kids because they know they're going to live a long time and they feel like parenthood is going to be an important part of their life. What I basically do is I always get, from my standpoint, I want to get a fertility specialist involved if the patient can afford it. There is certainly the cost issue that has to be, I think, taken into account throughout this because there are ways that people can get free antiretroviral medications, which are very expensive, but they can't always get low cost or free fertility services. That's something you have to keep in mind. In the case that I presented, access and cost was not an issue for those two gentlemen, and the outcome was very, very good because they really got the state-of-the-art, I think, kind of treatment. But this is something that, you know, it has to be carefully considered. I've encouraged couples to not just let nature happen, thinking that if the man has undetectable virus in his plasma, that it necessarily means he has undetectable virus in his semen. That is, as you heard today, not always true. It's low, but it's not always true, and infecting an uninfected female partner would not be the way they want to go. So, you know, I really asked them to consider it carefully, to understand that there is a great amount of experience, I can say a growing amount of experience in technology that's available to them, that they can take advantage of, to do research, to get involved with the fertility specialist, and really to go from there. because becoming a parent is not a simple, random sort of thing in my mind. It shouldn't be anyway, but should be planned. And in this case, especially so, because there is a risk of transmission. So I really try to make this something that is a planned event as much as possible.
Thank you. And most of the clinical protocols involve attempting to quantitate the presence of virus in these semen samples. The Bedford protocol uses a pre-wash quantification, and other protocols utilize a post-wash quantification of sperm in the sample just to help ensure their safety. Can you just address the pros and cons of both approaches, and is it necessary after the wash to even measure the sperm?
This is an interesting question. It's sort of a laboratory technique thing. One of the things to stress is that everyone who has looked at sperm themselves from somebody with HIV infection, as long as their CD4 count is above 200, the sperm themselves seem to be free of virus. So then once that's known, then you realize that the HIV is somewhere in the seminal plasma. It's not in the sperm. Semen comes from 4 major glands in the male tract: the prostate, the seminal vesicles, the epididymis, and the testis. So if you rule out sperm as being infected, then the other places that could be infected are the epididymis, the seminal vesicles, or the prostate. To try to address what the risk is of HIV sticking to a sperm head, which is essentially what you're doing, we decided that the most important thing to do is to discover if that particular specimen has any detectable virus in the seminal plasma or infected cells. We worry most about infected cells. I think it's important to recognize that no one has ever isolated infectious HIV virus particles from seminal plasma. The only infectious HIV that's been isolated from semen specimens has been from infected cells. Everything a fertility clinic does for a sperm wash and a sperm prep is designed to keep the sperm alive, and that will also keep the infected cells alive. So the biggest challenge, we think, to an infertility approach is to make sure that the sperm are not associated with infected cells. And we think the best way to do that is to screen the specimen before the sperm wash. There are limits to what you can detect in a post-washed specimen. These are all polymerase chain reaction, PCR-based assays. Sperm themselves are very inhibitory to those assays. So you can only assay a very tiny percentage of the post-washed specimen. Whereas before the wash, if you eliminate the sperm heads, you can test a very robust portion of the semen specimen as a whole, so that testing the specimen before the wash is in many ways a much more sensitive assay for the presence of HIV. Does that answer the question?
Thank you, Ann. Beautiful. You know, one of the problems we face for patients who are inquiring is access to high-quality medical care, high-quality reproductive medical care for individuals with HIV. Do you foresee any changes in the near future of how we can improve the access and availability to patients with HIV who want to have children safely?
Well, I think initiating programs of insemination, either vaginal insemination or intrauterine insemination, are key to that.
So this is the sort of thing that someone could do through a well-educated, well-researched sort of method, that they may not necessarily need high-tech services.
They would still need testing. It would need to be tested, but right, they would not have to go through IVF unless the sperm count is really low.
So you would suggest the way that they've done it before would be have the man submit a specimen for testing. If the testing turns out to be positive, turns out to be negative, I should say, and the specimen is returned post-wash, that they could actually take that home and inseminate it themselves?
In theory, that should be possible. Most women are concerned about that, but in theory you should be able to do that. The concern is not so much the technical issues with home insemination. They understand that it's timing. And so getting the timing right is usually better done if they've got the help of their doctor.
Sure. So I would ask you then, Guy, shifting it back over to yourself, is that how would you feel about that? Assisting pregnancy, but doing it in a way where you perhaps educated the patient, acted as a conduit to get the specimen sent to the right place, in terms of a washing lab, but then teaching the man and the female, or the men and the surrogate, to inseminate themselves. How well does that work?
Well, I'm concerned with cost, and one of the obstacles I see in the treatment protocols you're talking about is the cost of testing. And for many couples, they just can't afford it, yet they want to have children safely. So as a reproductive endocrinologist, I always try to optimize each factor, optimize the eggs, optimize the sperm. And my only concern with a home insemination would be it may not provide that couple the optimal chance of pregnancy, because the sperm may be somewhat compromised, both from the HIV, from the antiretroviral medication, and just other factors going on in the man. I would rather, insemination cycle in terms of cost is several $100s. It's not a high expense procedure like IVF, which will be $10,000 to $15,000. I would be a little nervous about the home insemination myself.
Doing it correctly.
Yeah, the doctor insemination is not that much more expensive. The cost of these patients is the testing
One
and
concern.
the preparation to get there.
One concern I always have is when I meet with young women who are coming in for their medical screening to be a gestational surrogate for a gay couple. How do I give them informed consent? How do I best talk to them about the potential risk? The surrogate mothers are amazing women from Middle America, very proud to be surrogates, and they're doing this to help others to experience the joys of parenthood. It's really all from the heart, and I'm very concerned with informed consent. I refer them all to Ann for counseling about the potential risk. Ann, what do you tell a young woman who wants to help a gay man have children?
I talk to the surrogates about a number of things. One of the things I talk to them about is confidentiality, because they don't often think about that. For instance, one of the questions I get frequently is, does she have to tell the obstetrician that one of the intended parents is HIV infected? Because that opens up a whole Pandora's box of what her exposure is, how many people does she have to educate, that sort of thing. And I tell them that as far as I know, that I've asked a lot of people, she does not have to tell the obstetrician that one of the intended parents is HIV infected. So that's kind of helps with the whole confidentiality part. I also want to make sure that she understands that nobody should tell her that we know there's no risk. We don't have enough babies, there isn't enough experience. We think there's no risk, but nobody should guarantee to her that there's no risk. On the other hand, the relative risk of HIV transmission is pretty low. So her biggest risk for this entire endeavor is for this being pregnant all by itself. So you kind of have to keep risk assessment in perspective. The most dangerous thing anybody does any day is get in your car and go somewhere. So in terms of her infection risk, we think we've eliminated it. We don't know that for sure. We also point out to her that the specimens that are used for the embryo that she's going to receive have been tested for many other pathogens besides HIV. And that does not necessarily rule them out from being used, but it's information that the infertility lab has when they decide what specimen to actually use.
I have a question. I understand the confidentiality issue, and I think that's an important discussion to have, certainly. And I like the way that you try to put into perspective what are the risks of pregnancy overall versus what's going on with this in terms of receiving a specimen that you possibly have. It bothers me a bit, though, that a surrogate would not tell her obstetrician that she was having what might be considered to be a high-risk pregnancy. For one reason, certainly she doesn't have to. There's no law saying she has to. I think very much is her own business. But I guess I can't think of a really great reason why she would not. Because in this day and age, one thing we're trying to do as much as possible around HIV is to normalize it, to make it part of everyday life, and to say, and help her healthcare provider give her the best care by giving the healthcare provider as much information as possible.
When I've talked to obstetricians about this, and I'd like to have Guy weigh in on this, their point is that they're going to test her anyway. Most obstetricians test a woman early in pregnancy and then later in pregnancy. So most standard of care, she's going to be tested twice. We're going to insist that she be tested at 3 weeks, 3 months, and 6 months after the embryo transfer. And to make that happen now, we actually send her a test kit. So we know all of that. The biggest problem, or one of the big problems with disclosure at every single level of her care, is confidentiality of the intended parent. And HIV disclosure, as much as you'd like to think it's just like having, hepatitis or something, is life-altering for people. So it frequently is. And so confidentiality to the intended parent, I think, is a huge consideration. Plus, it's important, we believe, that HIV not creep into her health record. The fact that she has been exposed to HIV, we're working very hard to make sure she's not exposed to HIV. And HIV exposure potential should probably not be part of her health record as long as all of her tests come back undetectable.
First of all, just make a statement that PrEP is something that has been widely recommended now for HIV negative persons at risk. However, in the CDC's and the WHO's guidelines, which have just come out this past summer, in July of this year, there is no clear guidance about using.
When do you think you'll know your plans?
Of course, that's primarily because of the data you presented here from Renatsa, and being a very small data set of only 37 couples. And therefore, it is something that we have to be careful about in informing the individual how good PrEP is. PrEP is good. It is good when used regularly in preventing HIV transmission from a positive person to a negative person. In most situations, treating the positive person, part of the couple, is the most important thing to do. You also need to protect the HIV negative, in this case oftentimes a woman, from becoming pregnant, from becoming infected while she's getting pregnant, having unsafe sex purposely. That's a good question. That's a very good question. I mean, the only medication that we have any data with at all is Truvada. Truvada was recently put into a preferred category as a nucleoside reverse transcriptase inhibitor. And in my estimation, I have actually, I'll be quite honest, prescribed it for a situation in which a couple could not afford semen specimen screening. The man was well suppressed in blood, and we put the woman on a PrEP regimen while she was getting pregnant. Tested her on a protocol very similar to the one that you used, Dr. Kiessling, to make sure she was not infected. And the pregnancy came out fine. It came out fine. But it's really kind of what I would call a belts and suspenders sort of approach, trying to do everything we can. And there is risk involved, and there is no good data to follow except for a small case series. But it is something I think that can feel a little more confident.
The biggest problem is the cost of the testing. The cost of the testing were just not so high, or if it were covered by insurance, if any of it was easier access, the problem would sort of go away.
Just any changes in the near future with the cost? Are there any
Yeah,
improvements in the technology that would enable us to bring the cost down?
Yeah, there are, and we would very much like to be able to switch to those. The methods that we're using have now been inspected by the state and by the federal government and now by the FDA. So to change that methodology, it's going to take some parallel this way and the new way. So it's going to take us a while to make that change, but we would very much like to be able to do that.
Many providers are offering timed intercourse if HIV positive partner is on ART as per HPT 052. And some believe sperm washing is not necessary. Does sperm washing offer any additional benefit in this scenario? What do you think?
Well, if you assume that the transmission rate without any antiretroviral therapy is 1 in 200 events, and you assume that what the sperm washing and testing does is decrease that to a factor of 10, now the risk is probably, for the best data we have, 1 in 2,000 events or 1 in 3,000 events. So it becomes a risk assessment. If you want to take that risk, then it doesn't offer any additional.
Yeah, I would say that, there is some early data from one ongoing clinical trials or clinical observation in Europe, which is looking at unprotected intercourse, condomless intercourse among both heterosexuals and gay men, to see whether or not someone who is well suppressed plasma-wise with their HIV can transmit HIV without a condom. Because remember, in HPT and 052, condoms were used very, very carefully, although pregnancies and STIs did occur. But I certainly would recommend to my patients that if they can access and afford sperm washing, it certainly offers a increased degree of confidence that they can create a pregnancy with a lesser chance. 10 times, I think, is a pretty significant change in terms of having a non-HIV infected partner.
One of the things that you discover when you go through a semen test, that the Bedford lab actually has a pathologist who sends us a semen specimen twice a year. And it's because he wants to make sure that his antiretroviral therapy is covering both his blood and his semen compartment. So one of the things that semen testing offers is a more comprehensive view as to how well this antiretroviral therapy is working.
Sort of, in a way, yeah. I mean, he's really kind of looking at compartments.
We tell him,
Yeah.
we say, 2 times, this isn't giving you any information, but he does it, we do it.
Right. What do you think? Would you add semen screening to a couple coming in saying, we just want to use the old-fashioned way, my partner's well suppressed and has been for a long time?
I mean, it's nice to offer it. I don't have to do it. It'd be nice to offer it as an option.
Yeah. What if they wanted a recommendation, though? They really try to pin you down and say, Dr. Ringler, we can save up and do it?
I like data. I like information. Sure, it would be nice to know.
And I think that this is an area where it's hard oftentimes, I think, for expectant parents who may not really understand all the parameters we just discussed today to want a recommendation. They want a recommendation. They want options, certainly, but they want to know whether or not to save up the money to get the sperm screened. Is that really going to be worth the extra several $1,000s that's going to take to do it? And I think that's something that we need to try to give them some guidance on.
I think patients often ask, they want to know the safest method that they can utilize to have a child without risk of infection, minimizing the risk of infection. And that would have to include semen testing for the presence of virus before you start.
And that's frequently more driven by the male than the female.
Yes.
She's frequently willing to take a risk and he can't.
Sure. And I like that word, safest, because I think that word encapsulates a tremendous amount of the recommendation. Safety is very important.
The second question is there an optimal time to wash the sperm relative to the creation of the embryo in the lab? Well, the sperm can be washed and frozen, and then it's thawed, and then we do a second wash on it in our program before using it for IVF ICSI. There's a couple-hour window between a second wash and the IVF ICSI. With IVF ICSI, we just need such a low number of sperm. We literally need 1 viable sperm per egg. And so if we're retrieving 10 to 20 eggs, that's 10 or 20,000 moving sperm. And post sperm wash, we're going to have millions of sperm in that specimen. So
How about in terms of men who are kind of going one step further from this question, men who are interested in submitting specimens for screening? What's the optimal? What do you require, or what would you recommend as the optimal time in their life to submit a specimen? Is there making sure that they have no urinary tract infections, they have no prostatitis, and those sort of things that have been checked out?
Yeah, if they have any urinary tract symptoms, they should go to their urologist first.
To try to make sure that their urinary tract is as stable and
I think-
uninfected and
Yeah.
irritated as possible.
I think it's important to point out that the sperm, quote, cryopreservation and washing, all of those methodologies were worked out 50 or 60 years ago for prize dairy bulls. And the technology is very stable. Once they're in the liquid nitrogen tank, they're stable for a very long time. And their sperm are shipped all over the world every single day because of the animal industry. Human sperm behave very similarly, so the methods have been refined a little bit, but basically the technology is incredibly stable and very well worked out.
Good to hear we're just like bulls.
Yep.
So you have any other questions? That's it.